Dr. Brodie, can you give us an update on Ezogabine?
Yeah. Ezogabine, as we call it in Europe, Retigabine, is the drug that opens potassium channels. And when we first saw it, we thought this is a mechanism that is genuinely unique, where we now arguably try and at least use drugs that work differently from the drugs patients have already failed. And the regulatory trials were really very, consistent, and we saw a decent dose response, reasonable tolerability. The animal model studies all seemed to be positive. There was great excitement amongst the basic science community about this molecule. When we got it to use, we realized there are one or two little drawbacks. The drug initially, we had to monitor EKGs, but that didn't really make much of a problem for us. And obviously patients with serious cardiac disease, we had to be a little careful. But the other issue that we had with it is the potassium channels in the bladder occasionally resulted in bladder symptoms and sometimes obstruction. And so again, we watched that. And that was okay, we can manage that, we know we can tell the patient about that. We saw too some psychiatric symptoms, which is common now to a number of drugs, including levetiracetam and perampanel, and we needed to manage that, and we tried to avoid it in patients with serious psychiatric comorbidities. And there was a problem with 3 times daily dosing, which we didn't like because the half-life is relatively short. But interestingly, most of our patients with refractory epilepsy don't worry about 3 times daily dosing. That's not to say they don't miss the occasional dose, but it doesn't seem to bother them. So we were starting to use it. We were realizing initially we had to titrate a little slower than we wanted to do. Unfortunately, about 4 or 5 years into its use, we were starting to see bluish-grey pigmentation of the mucous membranes, of the skin, and possibly also of the retina. The patients often didn't notice it, and once you started to see it, you started to see it more. There was obviously enormous concern and discussions with regulators, and the drug was relegated to drug of last resort for difficult to control epilepsy, and we started to collect data on the skin problems, and particularly on the retinal problems. Did it interfere with vision? At the moment, where we are is, it looks as if the skin issues are related to dimers of the actual drug or its active metabolite being deposited in the mucous membranes. It's a high dose long-term effect. The higher the dose, for the longer you take it, the more likely you are to see it. And it looks as if it's reversible. If you stop the drug, it slowly goes away. Regarding the visual situation, at the moment there's no evidence that it actually is causing visual impairment, but that work is going on, and GSK, the sponsors, are doing numerous studies, laboratory studies and clinical studies to try to get the bottom of this. Meantime, of course, we now have this interesting and unique drug rather in limbo. Who do we use it for? There are 2 points to note here. One is, if you started and you use it and you discuss the issues with the patient, and 6 months, 9 months, a year down the line, it's not doing the job, you can stop it, and there's not likely to be any issues. If you need high doses, and the patient whose life was paralyzed by bad seizures and threatened, arguably, by SUDEP, and these patients do extremely well and become seizure-free, then we can monitor the visual issues, we can monitor the skin, we can discuss it with the patient. And so in a way, the fact that the problem is down the line, I think gives us an opportunity of using it. And as we are starting to use it, if you start a patient on it today, you're not likely to see a problem for 4 years. In 4 years' time, I think we'll know where we are with it. And hopefully we'll be able to realize that this is not as serious a problem, that it's only a cosmetic problem than we thought. And I'm still hopeful that that'll be the case. So after not using it for a while, I'm starting back to use it again, I think that I've got a number of patients now who are doing well on it, a number who are seizure free on it, and they have no intentions of coming off it. And so in many ways the situation is fairly clear cut, and I certainly would encourage colleagues really to consider it when everything else has failed, because it's a genuinely unique molecule. And we're now, I think, beginning to understand the risk-benefit ratio, and it's perhaps not as worrying as we initially thought.
And Dr. Brodie, can you give us an update on Eslicarbazepine?
Eslicarbazepine, we've had Eslicarbazepine now in the UK for more than 5 years. And when we first got it, we thought Eslicarbazepine sounds awful like carbamazepine or oxcarbazepine, and it's not surprising because it's a very similar structure. And we thought to ourselves, why do we need a drug like that? And Eslicarbazepine acetate is the drug, and Eslicarbazepine is the active moiety, which accounts for most of the pharmacological effect. Eslicarbazepine is also produced from oxcarbazepine, but there's also lots of oxcarbazepine floating around, which is arguably causes more side effects. So it's a little bit different. And we thought, well, mechanistically it's not any different. But now there's evidence to suggest that it is, that there's 2 or 3 other effects, including an effect on slow sodium channels, such as lacosamide has, effect on calcium channels, maybe even potassium channels. And it looks in the lab very different from carbamazepine and oxcarbazepine, which is interesting. It's got a long elimination half-life of 25-26 hours, and so once daily dosing is encouraged, and this arguably can be helpful. Is it an enzyme inducer? Well, it's a mild enzyme inducer on 3A4, cytochrome P53A4, which is responsible for the metabolism of components of the pill, of simvastatin, rosuvastatin. Doesn't seem to affect cholesterol like carbamazepine does. It doesn't put the cholesterol up, so maybe it's going to be less of a problem long term. The trials used 800 and 1200 milligrams daily versus 400 and placebo, and the 800 and 1200 were pharmacologically effective. What we found was that we could use it with carbamazepine, and it didn't seem to have any effect on the efficacy in the add-on scenario. Side effects may be a little bit more, and so you would be thinking if you were adding it into carbamazepine, you might reduce the carbamazepine a little bit as you push the dose up. Its clinical practice is very well tolerated. As we started to use the drug, I began to realize that many patients were able to take twice as much as the 1200 milligram top dose in the regulatory trials. Sometimes maybe we had to reduce the dose of some of the other drugs, particularly carbamazepine, the patient's taking. And that made you think, well, if you're able to give more drug, are you going to get more efficacy? Because the driver really for treatment, and particularly as an add-on scenario for refractory epilepsy, is tolerability, because if the patient doesn't tolerate it, it ain't going to help. And if you tolerate it well, maybe you can increase the dose, and if there's a dose response, you can get better efficacy. And certainly we have a number of patients who are seizure-free with it as add-on. The trials looking at withdrawal to monotherapy here in the US have been pretty positive, and that was with 1200 and 600 milligrams a day. And I have absolutely no doubt that it will get a license for monotherapy fairly quickly, and arguably a once daily drug that's better tolerated than carbamazepine with less enzyme induction, probably less rash, maybe a little less hyponatremia, might turn out to be a really useful substitute for carbamazepine. And certainly that is the hope for it. Just out of interest, in Europe, we're doing a head-to-head randomized, double-blind, controlled trial between increasing doses of carbamazepine modified release and Eslicarbazepine acetate to see what the side effect profile is and what roughly the best dosing is for newly diagnosed patients in comparison to carbamazepine. And if that turns out to be equivalent, which is all we need in Europe, we'll get a license there, and we'll get a little bit more information about its use in newly diagnosed epilepsy patients. Mm-hmm. And that will finish probably in July of next year. So that information, I think, will inform prescribers in the US of the use of the drug on its own and its tolerability compared with carbamazepine. So I think the question really is asked is eslicarbazepine acetate better than carbamazepine? Is it better than oxcarbazepine? I suspect it probably is. Is it worth the difference in price? Mm-hmm. I think that we're going to have to find out as we use the drug more and more, and we'll see whether the patients like it, whether the doctors like it. But certainly that's a possibility. So rather surprisingly, this modest-looking drug might well turn out to be actually quite a big player for the future of the treatment of epilepsy.
Have you seen any toxicity that's unique to eslicarbazepine that's not seen with the other similar drugs?
We see far fewer rashes. We see rashes, but we haven't seen any, as far as I'm aware, any serious rashes like toxic epidermal necrolysis or Stevens-Johnson. I mean, I wouldn't be surprised if we see one or two. I mean, obviously, we're always watching out for that, but not. The hyponatremia associated with this group of compounds was very low in the regulatory trials, 1-2%. But once you get into clinical practice and you use it in the elderly along with SSRIs and with diuretics, it goes up a bit. So whatever you do for carbamazepine and oxcarbazepine regarding hyponatremia, you will well need to do with this. Mm-hmm. But from the toxicity point of view, again, we haven't seen anything different. It's just sort of less of the same, if you like. Mm-hmm. But the other two drugs have done, are established treatments. So why should eslicarbazepine not turn out to be similar? And at the moment, there's no reason to think that we're going to find any exciting new side effects like with some of the other new drugs recently. Mm-hmm. And we just have to learn what the best doses are for the patients and who to monitor and how to keep an eye on sodium, etc., etc. Mm-hmm. So, as I always say, this drug is a pussycat. It does what it says on the tin.
Uh-huh. Well, thank you very much, Dr. Brodie.